Welcome to Health or Consequences, a regular podcast series under the Commonwealth Magazine's Codcast label with an aim to help sharpen our listeners' understanding of key Massachusetts healthcare and public health issues. I'm one of the co-hosts, Paul Hattis from the Tufts University School of Medicine, and I'm here with my colleague, John McDonough from the T.H. Chan School of Public Health at Harvard University.
Nice to be with you this morning, Paul.
And our goal of these podcasts is really to bring a discussion of health issues to our listeners from a variety of people, some who've been active in the healthcare and public health space for a while in our state, and some who are new to the scene. And today's guest falls into the latter category, Mr. Michael Carson, the CEO of Harvard Pilgrim Health Care, who's been in that position less than a year, is with us today. So welcome, Michael.
Good morning, Paul.
And we'll get things started by you just saying a little bit about your background for our listeners.
Yes. Again, good morning. Pleasure to be here. Thank you. Spent about 25 years in the industry leading payer, provider, population health organizations across the country, serving commercial, Medicare, Medicaid, dual-eligible populations. Also spent a fair amount of time in non-for-profit health insurance companies in Washington State and other places, as well as for-profit organizations and private equity-backed organizations. Joined Harvard Pilgrim just 2 years ago. When I initially joined, I assumed responsibility for 3 primary lines of business: our commercial business, Medicare business, and our national TPA business, third-party administrator business, as well as core functions that really drive managing cost, managing revenue, managing overall performance and growth for the organization.
And became CEO last year in around June of the year?
Middle of the year.
Middle of the year. Okay.
So thanks for being here today, Michael. Very nice to meet you and to have you as part of this program. So Harvard Pilgrim went through a tough number of years in the middle part of this decade financially, having some significant losses and having to sharply increase premiums. And we've seen in the past year a major turnaround and a significantly improved financial situation. Can you talk about Harvard Pilgrim and how it's doing? Compare it with your assessment of the Massachusetts health insurance market more generally, and where you see Harvard Pilgrim now and where you hope to see it in a few years.
Absolutely. Thank you, John. So, yes, 2014, 15, and 16 were tough financial years for Harvard Pilgrim and, quite frankly, many healthcare organizations. Much of that had to do with the introduction of the ACA and various rules and health insurance companies trying to figure out how to manage through the risk adjustment process that was introduced with the ACA, which was a bit different than what perhaps Medicare organizations had been familiar with under CMS rules. So as companies were going through that, understanding what the populations were that they were bringing in and how they needed to be cared for and engaged, as well as managing their appropriate coding and familiarizing themselves with how the rest of the organizations would do that coding, that created some financial challenges for organizations, Harvard Pilgrim included. In the meantime, we've driven a significant turnaround, as you mentioned, at Harvard Pilgrim. There were other factors that drive it. Harvard Pilgrim, as you know, has business outside of Massachusetts, so we also operate in Maine, New Hampshire, and Connecticut. We have commercial business and Medicare business, and we also have our national TPA business. So all those components at any given time may fire and may not fire. So there were other components as well that drove to some of the financial challenges that Harvard Pilgrim had. What we've done, though, beginning in very late in 16 and then really executed in 17, is a very deliberate, targeted strategy to understand, one, the populations that we serve, how do we appropriately engage them so that as much as possible we can engage with them prior even to their effective date. So member onboarding is key. Once we have them on board and they're familiar with us and we're familiar with them, it makes for a smoother path of identifying what their needs are and helping guide them through the healthcare process in a better, more effective way, which is good for them, drives better health outcomes, but it also reduces costs. So Harvard Program has been very much focused on understanding who our members are through data analytics and data-enabled technology and interventions, and then really just rolling up our sleeves and engaging in the community with members and providers and driving provider collaboration. In addition to that, Harvard Program has undergone tremendous efforts in looking at where we spend money, frankly. You know, are we It's a 50-year-old company, has a great tradition, focused on quality, service, innovation, provider integration, many, many great things. But we understand that the things that have made us successful the last 50 years aren't necessarily the things that are going to make us successful the next 50 years. So we have to evaluate where are we spending money. Are we spending money aligning resources with the things that are driving the business today and tomorrow rather than the things of the past? So we've had to reallocate some resources to ensure that we meet the customer's needs as well. So it really, when you look at a profit and loss center, we did with a fine-tooth comb, went through the organization and said, who are we serving, where are we serving them, how are we serving them, are we being paid for appropriately for the services that we provide and the services that we cover? Are we managing medical costs appropriately through member engagement, but also the provider contracting, vendor contracting, and where necessary, did some recontracting there. And then looked internally, are we spending the right amounts of money on the right things internally? And the way all that comes together is a positive outcome. So again, 14, 15, 16, significant losses. 17 was already a great recovery year for us, frankly. And then 18 has turned out extremely well. We're very proud of the efforts of the team.
Is Harvard Pilgrim an outlier in terms of how well you did last year, or are all the plans doing well and you're just sort of part of the larger party?
Both. So I think in some ways you did see a turn, and this is typical in healthcare. You see cyclical activity in terms of health insurance company performance. So other organizations also had a decent year. Again, figuring out how to manage risk adjustment within the ACA and doing other things to perform. But Harvard Pilgrim, in my opinion, of course, additionally excelled in managing costs in a tighter way, improving our administrative cost position to build an even stronger performance going forward. As I look at our rate of improvement, roughly I would say about half of it is based on things that affect the industry overall in terms of figuring out risk adjustment, and half of it is about things that Harvard Pilgrim did specifically.
Mm-hmm. Where's the volatility in the Massachusetts health insurance market right now, and who is doing well, and are your rivals, and who is underperforming?
I have great respect for all the health insurance organizations in Massachusetts. It's a unique and great marketplace. As we've talked about earlier, I've done this in pretty much every state across the country, and one of the neat things that I've learned is that every state is different. When it comes to risk contracting, for example, Massachusetts is good. There are lots of states across the country where risk contracting just hasn't taken hold yet. Provider organizations aren't there yet.
When you say risk contracting, can you explain what you mean
Absolutely,
for people
yes.
listening in?
Thanks, John. So it's provider risk contracting, where a payer, like Harvard Pilgrim, and a provider organization share in the financial risk of serving a member. So there's a financial exchange that aligns the focus of both organizations to create the best health outcomes and therefore the best cost management structure. So where I'm going with that is in Massachusetts, the non-for-profit organizations have been here for a long time, have done great work in partnering with the state, partnering with the excellent healthcare system that exists in Massachusetts, and have all served the communities very well. Clearly, some of us are bigger, some of us are smaller, some of us are more diverse, some of us are less diverse. So, so we have our backs and forth with that. Quite frankly, Harvard Pilgrim is we want to drive more diversity in our book of business. We like the fact that
Where do you want to go?
More government programs. So we're relatively small compared to competitors on government programs. So we're looking to build our government programs business.
So re-entering Mass Health?
Potentially. I've spent many, many years in serving Medicaid members and dual eligibles and long-term supports and services type members. So I think it's a tremendous opportunity to serve those populations. To me, personally, when you spend so much time in an industry, and I know some people's perception of health insurance as, people in suits and trying to figure out how to make a dollar, there's really a lot more to it. Most people in health insurance organizations have a deep passion for serving members and making a difference in healthcare. For me personally, the business and personal mission component really come together when you serve underserved populations, frankly, because you can create access that maybe hadn't existed before. You can make a change in generational views of how the access to healthcare system through some education and engagement that's really fun to see. when a family learns that you don't have to wait for the worst of the worst thing to happen and then run to the ER. There are other ways to engage with healthcare, with your provider, with your doctor, with your insurance company.
Let me build on those set of questions in terms of our specialties here in Massachusetts. As you've noted, we've essentially been dominated by the nonprofit plans, which also many of us think they have amongst the highest, if not the highest rated health plans in the country. But your colleague, when he was on here on this show, Andrew Dreyfus, seemed to be a little bit worried about competition coming in from some of the national for-profit plans in the face of mergers like Aetna CVS or Cigna Express Scripts. What are your thoughts about all of that? And are you as worried as he seemed to be?
Absolutely. Andrew's a great guy. I've actually in my career spent a lot of times working for Blue Cross Blue Shield plans, so I'm very familiar with his organization as well. The fact is, my personality is like, bring it on. So I'm okay with it. I've spent years working for the nationals, quote unquote, as we say. I think clearly it's a new level of competition. But as I look at Harvard Program and the improvements that we've made, frankly, I set the bar extremely high, and I say we're going to measure ourselves against national benchmarks. We're going to measure ourselves against what the nationals are doing, what the local great regional plans are doing. So to me, it's just another level of competition, and we have to continue to sharpen a pencil to do and succeed in the marketplace. Clearly, there are new dynamics to that, right? So you look at a United Healthcare, for example, that also has the Optum arm. Many things that they can leverage with that, right? Mm-hmm. For a group potentially being sold on particular services that the national has as a health plan, but also as ancillary activities that are attached to it. So Harvard Program has to continue to innovate and say that we can do the same thing.
Are you worried at all that something can come in here and underprice you and take market share away? Is that a real concern?
That can happen today. I mean, it's not. I don't think it's a new threat, I guess, is what I'm getting at. Is that we have deep relationships with our provider partners in the community. Every year, every other year, every 3 years, we're going through negotiation rounds, and it's our job to do the best we can with that and to prove value, right? So we have to stay a certain size so that we can be meaningful to that provider partner, and we have to do a great job serving the provider appropriately. You guys, I'm sure, are familiar with quadruple aim. Mm-hmm. So provider satisfaction is key as well.
So there's been a long history between Harvard Pilgrim Health Care, going back to when I was on the board in the early 2000s, and United Healthcare. Is that still there? Is it still a special relationship? And what's the relationship between United and Harvard Pilgrim these days?
Yes. So we've had a joint venture relationship for many years. Clearly predates me. It's really focused on us accessing United's national network, provider network, and United being able to access our local network in Massachusetts. Because of the competitive component that we just spoke of, the nationals don't always have an easy time contracting with key provider organizations in Massachusetts, and it's been to our benefit, right? So what United does is, at a different rate, is able to leverage Harvard Program to have some access to the Massachusetts network. So we have joint products that get offered that are sold through either Harvard Program or United process, and members that United signs up are able to enjoy access to a Massachusetts network, and we're able to market, and not just being a regional network organization, that we actually have access to United's national network.
Is that a large part? Is that a large part of your book of business, or relatively
small? No, it's maybe 10% or so.
Okay. So about 2 years ago, it emerged in the news that Harvard Pilgrim and Partners Healthcare were in negotiations on potential merger, consolidation, whatever. Then late last year, all of a sudden, it was sort of like, forget about that, it's not happening.
Never mind.
There's never any, from what we saw, any serious presentation of the public about why did that happen, where did that come from, and then what happened to the conversation between them, because I think even though there wasn't a lot of public discussion, everybody was paying attention and wondering where this was going to go. So can you give us the story behind this?
Sure. We just talked a lot about the network and the provider-payer collaboration. So that's really where this stems from. Healthcare, as we know, very complex, very costly. Consumerism is increasing. So it's in our best interest to think about provider-payer relationships and how we can better serve our members, to engage them appropriately, create better outcomes, and manage costs in a better manner within the healthcare system. So that's where those conversations came from. It's really focused on provider-payer integration as well as collaboration. And that happens at many, many levels. So provider-risk relationships that we explained earlier are on that continuum. Joint venture relationships. Harvard Pilgrim has a joint venture relationship with 3 hospital systems in New Hampshire, where we jointly own a population health company, and we manage and serve members through a relationship between Harvard Pilgrim and those hospital systems, and again, joint venture type of relationship. Many risk relationships here in Massachusetts. And then potentially, if something really aligns, then you talk about a merger of 2 organizations. So our conversations with partners evolved from how can we make a better difference in serving members in Massachusetts primarily, right? And that could have ranged in any of those levels. So that could have been a deeper risk relationship with partners, and then perhaps something stronger than that. But we were evaluating what those opportunities are to offer special products, special access, special care for members in Massachusetts through a partners relationship. And there were lots of benefits that could have come from that, but also we have to understand while we're 2 excellent, highly rated organizations, there are also nuances to how our organizations function. And it's not easy just to slam a provider and a health insurance company together. So we evaluated various options along the way. And through that process, explored what could work, within our own organizations, evaluated how far we'd go in terms of a relationship, and through those evaluations, it didn't come together at the time.
Should a listener to this conversation say, gee, if that transaction had gone forward, then Partners' almost exclusive, or at least primary commercial insurer would have been what Harvard Pilgrim coming together under with Always or whatever structure would have been exclusive to them?
So I think in today's world, sort of the exclusivity and single payer focus for a provider organization is tough, right? So I don't.
There are a few examples around the country, right, but not many.
Exactly.
Yeah.
So I think that the idea of that type of relationship, meaning that partners would only see Harvard Program / Always type members, is not, obviously that's not reasonable. Similarly, when you look at key provider organizations in our state, in our Commonwealth today, the notion of them having too much exclusive relationship with a single payer is not feasible. And you see more and more of a multi-payer strategy from a provider standpoint. So none of those discussions were focused on Harvard Pilgrim being exclusively focused on partners providers, nor partners providers serving Harvard Program only members. It was a very open concept of evaluating how to best make a difference and make a dent in the rising healthcare cost and the need for access in our community.
So are you saying that the characterization in the media of the conversations as being about a merger between Partners and Harvard Pilgrim was an exaggeration, an overstatement?
No, as I said, the range of opportunities were discussed. Anything from just deeper contractual relationships to is there a possibility for companies to come together? But again, those kinds of conversations, not that they happen all the time, but they're not unusual. It's it's such a demanding environment that you have to explore options.
Mm-hmm. It's unusual that it becomes so public, though.
Well, it's Massachusetts.
Okay,
Right.
Paul.
Well, let me move the conversation back to something you started this off with, which is focusing a bit on costs. And we take a particular area of interest everybody's talking about, which is pharmaceutical spending. And maybe to tee that up, I want to give credit to your medical director, Michael Sherman, and others who last August in Health Affairs published an interesting article looking at Harvard Pilgrim's own data over a 5-year period showing how total pharmaceutical spending, whether it's including sort of the the outpatient pharma spending along with the injectable or other drugs that happen sometimes in physician offices, went from 20 to 25% of all commercial spending, a number that's higher than even many of us appreciate. And I know Harvard Pilgrim focused generally on that issue, has in some ways been a national leader. I think you have 15 kinds of specialty pay-for-value contracts now, where if for certain specialty drugs, or sometimes referred to as next-generation therapies, you don't get the full durable value of that therapy. There's some money coming back to the insurer, having already paid the cost of that drug. Tell us about that specifically, but also your thoughts about this whole pharma space, and especially that high-cost specialty drug space.
Yes. To me, it starts with value. I've spent a career focused on creating value in the healthcare system, worked for a 100% provider risk organization on the health insurance side, driven value-based relationships all over the country. No different from pharmacy. As you quoted, 25% and rising of the medical spend. And with the introduction of new high-cost specialty drugs, and other high-cost innovations in that regard, it's great to be able to have those medicines come to market and do what they do for patients. But when a claim is made, it's important that when it's not achieved, that there's some cost implication, because the cost is just so high, right? So value-based, outcomes-based contracting is phenomenal effort that Harvard Pilgrim has undertaken. And we're not the only organization doing it.
Does it save much money at the end of the day?
So it's still too early to say. I think the potential is there to have a tremendous impact. I think the ones that we have in place are a bit early. They take some time to develop. And again, because they're high cost, it's, a patient here, 2 patients here. So it's not a broad population that's being affected on this right now. But to me, the most important thing is we're setting the precedents for how this should be done going forward. So setting the right price point, important, and there are lots of components to just getting to the right list price to begin with on pharmacy. But then in addition, implementing these types of outcomes-based contracts, maybe just for a few things, small things today, but tomorrow, once we lay the groundwork for how this works, tomorrow it can impact many, many other drugs.
Does government regulation have a role in this pharmaceutical cost space?
Yes, for sure. So from a pricing perspective, and we'll see where the chips fall in terms of government regulation, but the starting price is important, right? So we don't want to be a furniture store where an outcomes-based contract gives a 50% discount, but the price should have been, 75%
I thought you were
less.
going to say carpet store, but I'll accept furniture.
75% less to begin with. So the initial price has to be set correctly, and that's where we can use some government regulatory help to ensure that the starting price is appropriate, and then we can work from there.
So let's talk about hospitals if we can for a second. So last year we saw the green lighting of the major new consolidation, Beth Israel, Lahey Health. Some people think, myself included, we're now in an era where instead of having one Partners Healthcare dominating force in the hospital market and the healthcare market, we now have 2 partners instead of one. How are you viewing this? Are you looking forward to this competition? Are you concerned, as the Health Policy Commission was, that this is going to have a major, unfortunate impact on costs? What's your sense of that and of the broader hospital sector in Massachusetts now?
Mm-hmm. So I think studies have been published that mergers of hospital systems like that drive cost up, right? And Health Policy Commission, with whom I've spent significant time and have great respect for, recently had a meeting with them, and I was amazed. I've spent so much time focused on medical cost management initiatives, and meeting with the team there and seeing that they're aligned directly on the same things was very, very good to see. Dr. Tab and I spent significant time talking. One, congratulate them on completing the merger. 2, believe that there's an opportunity for those 2 organizations to partner with companies like Harvard Pilgrim to make a difference in the community again. I think that, yes, there's potential for cost increases, but I think there's also tremendous potential for us to collaborate in creating innovative products, in creating innovative access, and to really drive that member engagement piece that we talked about earlier. That done correctly, we can actually make a difference and bring healthcare costs down, improve quality, improve access, but bring costs down in the right collaborative manner. So to me, again, I see it as an opportunity, a little bit of a glass half full kind of perspective. I think we have great partners in the Commonwealth, and I think that through collaboration, we can actually make a difference and bring costs down. Yes, clearly it will bring yet another round of negotiation components, but I don't see that as much different than what we do today.
So do you think the Health Policy Commission was to negative in terms of its assessment?
No, I think the risks that the Health Policy Commission outlined are there. I think it's our job now to roll up our sleeves and go manage it appropriately and not just let the chips fall where they may, but actually, influence it as much as we can.
Let me mention the notion of doing things innovative in a contracting way, and you also said this is the 50th anniversary. I assume that refers to what was the Harvard Community Health Plan
Yes.
in its origins, and you're at least the insurance side of that through. And they were if I understand correctly, maybe John, correct me if I'm wrong, a fully capitated staff model HMO. And we read recently, for example, about Atrius, how now on the PPO side, the Blue Cross has cut with them a fully capitated arrangement. It's been on the HMO side, but on the PPO side, where you tend to think sometimes you have less ability to control spending. What do you think about that, and does that portend anything else for you or others moving more to those full risk kind of capitated arrangements?
Yes, so Dr. Strongwater and I, CEO of Atrius, discussed this quite a bit, and we're in consistent communication in terms of furthering our relationship. As you pointed out, provider risk relationships, as we sort of walked through earlier, very much focused on HMO type business, right? You have a PCP, there's sometimes a referral process to a specialist. That's when a provider organization is willing to take on risk. In a PPO relationship, where patient goes to whatever PCP, self-refers to a specialist, it becomes less controllable. So generally, you don't see risk relationships on PPO. However, I think the instance that exists here, and Dr. Strongwater and our teams have discussed this a bit, and we'll potentially do something as we move forward, is if you already see practice patterns today, right? So you know that patients that are going to see Atrius doctors, for example, Atrius already knows where those patients are going. And even though they have the choice of going to whatever PCP they want, they tend to go to this one or these two. Even though they have the choice to go whatever specialist they want, data will show Atrius that they go to these. So it's a risk, super risky to take on PPO risk, but it's likely a calculated risk for Atrius, given that they see the practice patterns anyway and the utilization patterns. So in that regard, it really becomes a cash flow play. So now Atrius receives capitated payments from Blue Cross Blue Shield for its PPO membership. It creates upfront cash flow through that capitated payment that allows Atrius to invest in growth and strengthen its organization. Harvard Pilgrim is right there, and we'll have similar discussions as we move forward.
You think other provider organizations might be right there too?
So again, as leading a provider organization in my past, I've taken on risk for PPO members, and you try to negotiate that with maybe some just upside opportunity and then take on just a little bit of downside risk. But it's manageable. Again, as long as you have the insight, you don't do this raw. You don't do this on membership where you're a tiny provider and there's likelihood of those patients going wherever. If you're Atrius size, you can do that because you have more insight into where the patients are really going.
So almost out of time. Last question we have to ask. Medicare for All is a big conversation across the country right now, replacing, as one legislator said, Kamala Harris, candidate for president, says, let's just get rid of private insurance. Good idea? Not so good idea? What do you think?
Let's wait until I retire. How about that? Until I'm eligible for Medicare, maybe we can do that. So today, we have to, it's an important thing to consider and discuss, right? And 40 to 60% of household and government budgets are spent on healthcare, and it's rising. We've talked about how complex the healthcare system can be. We're living longer, life expectancy is increasing, so the cost of that is not going to decrease. There's no sort of visibility on how this is going to get better, so we have to keep the conversation going. Personally, as I said, I spent last couple of decades serving government programs type members and products. So I think there's a place for them and there's benefit to Medicaid and Medicare programs so they can work. But there are also downsides to them. There are access issues. There are limitations from a benefit design standpoint. So we have to make sure that we clearly understand those. Frankly, I was born and raised in Germany. Mom's German, so I remember being, I don't know how old I was, but I think my mom received like these 3 certificates to go see the doctor, and you better use them judiciously. So we need to ensure or understand that going to a program like that is going to mean change in how we access healthcare. Because if we just allow it to think that it's sort of free healthcare and access is unlimited, those costs are going to spiral really out of control.
A big part of your business at Harvard Pilgrim today is in the Medicare market already. You're in the part of Medicare called Medicare Part C or Medicare Advantage.
Correct.
It's a big part of your business. Some people have suggested maybe a pathway to Medicare for all would be Medicare Advantage for all. Have you ever thought about that or considered that? Because the insurance companies like Medicare Advantage, and it actually has increasingly good quality metrics and even cost performance.
I think that's a great point, John. I think at the end of the day, it's a joint solution. I don't think it's a single-payer government programs, no private health insurance organization solution. I think it's a combination. And today, as I said earlier, my Medicare Advantage business isn't big enough. We need to have it bigger at Harvard Program, but I used to lead Anthem's Medicare business on the East Coast from Maine to Florida. So I have lots of Medicare experience, and I've led another organization's Medicare business across the country. The opportunity that comes from government and private insurance working together, as we do for Medicare Advantage, is tremendous, to your point. And I think there's a lot of opportunity in that.
Okay, thanks, and I'll turn it back to Paul.
Michael Carson, CEO of Harvard Pilgrim Health Care. Thank you very much. Our next podcast will be with Manny Lopes from the East Boston Neighborhood Health Center.
Thanks for joining us.
Thank you very much.